Good afternoon, everyone. I'm Johanu Botha, Operations Planning and Logistics Lead for the Vaccine Implementation Task Force. Earlier this week, we hit another milestone in our vaccine campaign. More than 60% of all adults have now received at least one dose of the vaccine. Each dose administered is helping to protect us and our loved ones and supporting our return to the activities that we love. This week, we're aiming to give more than 98,000 doses, almost 100,000 doses in our super sites, pop-up clinics, urban Indigenous clinics, and through our focused immunization teams. And we will completely exhaust the vaccine supply we have on hand in 6 days, less than a week. Next week, we expect to give about 76,000 doses through those same channels. Of course, the number is lower. The number of doses we're providing every week, though, shifts based on the number of doses we are receiving from the federal government. We're also making progress in making the vaccine more accessible to more people. Gimli will immunize its first clients on Saturday, and the super site at the Legion in the Paw will open on June 8th. Today, we are also expanding eligibility for people to book their second dose. If you received your vaccine on or before March 29th, today you can book your second appointment. We'll be emailing everyone we have contact information for, but if you know this is you, you don't have to wait for us to book. In order to book, you do need to know which vaccine you received and the date of your first dose. People can access that information online. And if you don't have internet access, you can contact your local public health office. We'll continue to regularly expand second dose eligibility based on supply and based on the clinical guidelines set out by Dr. Reimer and the medical team. We are planning for all eligible Manitobans to receive their second dose, should they want one, by end of July. But you cannot get your second dose, of course, without getting your first. So I want to ensure people know that there are appointments available this week at the Lila Super Site in Winnipeg. If you've been waiting to make an appointment for your first dose, or if you're newly eligible, these are the fastest appointments available, some as early as tomorrow and the day afterwards. And if you've already booked but want to speed things up, you can move your appointment up to Lila this week and leave that later place for someone else. While regular announcements will be made about available appointments and our plans for second doses, people are encouraged to visit protectmb.ca often, or follow @MBGov on Twitter for the most up-to-date information. More vaccine is arriving in Manitoba, and we are rapidly administering the doses that we do receive and get them to people across the province, now in both first and second doses. And with that, I will turn it over to Dr. Reimer.
Thank you. Good afternoon. I'm Dr. Joss Reimer, Medical Lead for the Vaccine Implementation Task Force. Today, as you've heard, more people will be able to book their second dose of vaccine. So if you received your first dose on or before March 29th, you are now eligible. À compter d'aujourd'hui, encore plus de gens pour prendre le rendez-vous pour la deuxième dose. Si vous avez reçu votre première dose le 29 mars ou avant, vous êtes maintenant admissible à la deuxième dose. When you call or go online to book, you will need to know the date of your first shot as well as the type of vaccine that you received, because at this point we are using the same product for dose 1 and dose 2. You can access that information online through our website. You can also call your local public health office if you don't have access to the online portal. Getting 2 doses of the vaccine provides the fullest protection possible against COVID-19. Because we have focused so much on getting out first doses to as many people as quickly as possible, So far, we haven't shared much further direction around for those who have received 2 doses, because that number of people was relatively small. But as we are opening up appointments for second doses more broadly, I wanted to share an example of one of the benefits of being immunized, apart from the health benefits and prevention of COVID. If you are fully vaccinated, that means that 2 weeks after you have received 2 doses, you will no longer be required to self-isolate if you are a close contact of a COVID case, so long as you don't have any symptoms. Si vous êtes pleinement vacciné, c'est-à-dire que vous avez reçu votre 2e dose depuis au moins 2 semaines, vous n'aurez plus à vous isoler si vous êtes en contact étroit d'un cas de COVID et que vous ne présentez aucun symptôme. This is another great reason to book your second dose as soon as you are eligible. However, I want to be very clear that this is still a decision and still requires direction to people as part of the public health and the case and contact investigation. Public health officials will confirm with you that you are exempt from self-isolation based on your situation. You don't have to make this decision on your own based solely on your immunization status. I also want to thank Manitoba's young people and their parents for stepping up when it was their turn. Less than 2 weeks ago, on May 14th, we announced eligibility was expanding to include youth aged 12 to 17. Since then, about 45,000 appointments have been made for this age group. We look forward to seeing you at your vaccine appointments in the days and weeks ahead. Before we go to questions, I wanted to talk a little bit about some questions that I continue to hear from people and that we're seeing online. We are still waiting for the findings of a study about exchanging products for dose 2. This applies most urgently to people who received AstraZeneca. Right now, the advice from the National Advisory Committee on Immunization is clear that to the extent possible, we should use the same product for dose 1 and dose 2. However, we are looking to receive some information from a UK study, and ideally this week, that will help us know whether or not we can shift our policy going forward. We are going to monitor this very closely, and we're working directly with the National Advisory Committee on Immunization to make sure we are providing Manitobans with the best option for protecting them. For AstraZeneca specifically, we recommend the 12-week interval between doses, not because of any issues around supply, but because the trials showed that the efficacy, that is the ability to protect people, was much better when the second dose was given more than 12 weeks after the first dose. However, I know that there is a lot of talk about the increased protection offered by a second dose compared to 1 dose alone. So if you are someone who has received AstraZeneca and you're concerned about the recommended time frame in between doses because you believe that you are at greater risk from COVID, I want you to know that there is a process for you to get your second shot sooner. A physician or pharmacist can conduct a clinical assessment and prioritize you sooner than 12 weeks. So if you are in that situation and you feel you're at greater risk due to a health condition or a greater risk of exposure to COVID, this may be an option for you. I want to reinforce the fact that every vaccine available in Manitoba is safe and effective, and that for those people who chose to get AstraZeneca early on, that they made the right decision. You protected yourself, you protected your families. You may have been exposed to COVID over the last few months, and because you received that vaccine, you prevented an infection. You may have prevented someone from ending up in the hospital. You may have decreased the number of cases that contributed to wave 3. So I want people to feel confident in the choice that they made for AstraZeneca, even as we stick for now with the previous policy of offering the same product for dose 1 and dose 2. As Johanu mentioned, we have appointments available at Lila this week, and we want those vaccines to be in arms, protecting people, protecting our communities. I know that it's been challenging to keep up to date on what's been happening with AstraZeneca, and I hope that we are answering Manitobans' questions about this vaccine and about all vaccines as quickly and as clearly as we can. I know there's been concerns about how quickly the vaccines were developed, and there may be concerns about one product compared to another. But I really want to encourage you, if you are eligible to book through one of our super sites, to book for whatever first dose is available to you. Moderna, for example, has been working in mRNA technologies since 2012, developing many different therapeutics and vaccines over the past decade. And so the work that they have done has led them to be a global leader in mRNA technology. And we see that in the trials, as well as the real-world data, that both Moderna and Pfizer are providing excellent protection. So the best vaccine for you is the one you've received and the one that's available to you. And that's critical to our vaccine response, to ensure that you're protected. We know that the third wave is here. And for those of you who have waited to make your appointment, we encourage you to call now, because you can get in at Leela tomorrow or the next day. And with that, we will turn to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from CTV Winnipeg, Michelle.
Hello. We got data on race and ethnicity in COVID-19 cases this morning, which suggests there may be vaccine hesitancy or barriers among many BIPOC groups. So how will this information help with decisions going forward now, both logistically and clinically?
I can take the logistics piece and then pivot to Dr. Reimer. So, when we first moved to our velocity approach, which is sort of our technical word for getting doses in arms as quickly as possible, that's the clinical direction we got many weeks ago, and we really started pivoting hard to using our bigger pipes, our super sites, so to speak. And that approach has worked well. We're moving through doses quite fast, and as long as we have supply, everything is pointing to getting first doses into arms by early mid-June. However, the information that we're getting from clinical experts like the ones provided this morning, and that might come from Dr. Reimer and our medical team, might suggest that beyond that 70% uptake, we need to use different delivery models, ones that look different than super sites, that reach deeper into communities, that are delivered more by community partners, that are put together in a different way, so we can reach those who may not be vaccine hesitant per se, but need the vaccine delivered in their communities by trusted voices. So we've got plans in place to pivot in that direction or start emphasizing that a bit more, using many of the lessons that we've learned through urban Indigenous clinics, working with community partners, both in terms of communicating with the community, but also in terms of actually operationalizing a clinic. So those plans are in place. We're waiting for when that right pivot moment comes, when we start emphasizing those kind of accessibility, smaller pipes a bit more, and move a bit more away from the super sites. It's always been that balance, but we're preparing for that on the logistics and planning side. But over to you, Dr. Reimer, on the clinical aspect.
Yeah, the data that Dr. Anderson presented earlier this morning is critical to the clinical guidance. We've seen excellent uptake throughout Manitoba as far as numbers go, but that uptake has not been consistent in every community, in every location. And so now is the time that we have to very seriously think about who is not being well served by our existing structures. We want to make sure that everybody has equal access to the vaccine, and for many people that means we need to put more effort into bringing it to them, both as far as geography, but even more importantly than geography, by bringing it to them in spaces that they're comfortable with, and with people that they trust. So this work has already been going on. We've been doing consultation with many of the newcomer groups. We have some of the medical officers of health, particularly in the Winnipeg Regional Health Authority, that are meeting with those groups, both to present information to them, to give them the tools and information that they need to reach the communities, but also to get information back from them about how those communities can be best served by us. So some of the examples around where supersite may not be the best option for some people is where there may be a language barrier. One of the things we did with the call center is ensure that there was on the phone interpretation available both for booking and on site. But that's still, that helps and certainly reduces that barrier substantially, but doesn't completely eliminate it, and doesn't get rid of the intimidating atmosphere of booking an appointment or coming to a super site. And so if we can find ways to tailor our approaches to those communities, we may see that the accessibility plays as big of a role as any hesitancy might in those communities. So this work has been going on for many weeks, and we'll be working now to start to implement as soon as we can to reach as many populations as possible, taking a lot of the lessons from the First Nations leaders on the successes they had in their rollout to 63 communities, and the successes and challenges from our urban Indigenous clinics and some of the other pop-ups we've done, such as the one at Knox Church.
Great, thank you. I'm wondering, why are there so many appointments at the Leela super site? Do you know?
So from a booking and logistics perspective, I won't speculate on any hesitancy at this point. What is new this week is this is the first time we're using Leela getting close to its full capacity, although we don't have enough supply to really leverage it entirely. But every single Moderna shipment that had arrived before this week, a good amount of that we allocated to our First Nation partners, and then we used the rest mostly through pop-ups, but focused immunization teams too. The pop-ups are highly successful. That mRNA gobbled up through them. This was a week where the full amount of Moderna that we got, we were able to send through Leela. So, operationally, what might be new is we suddenly have this large pipe in that part of the city. There's thousands of appointments left there because of how big the pipe is, and we're hoping that they'll be gobbled up fast. We're watching to see, and I don't know if there's anything that can be said at this point in terms of any hesitancy accessibility issues, except that it is a large super site. So down the line, we will look, as Dr. Reimer just said, at different ways of delivering if the super site model reaches sort of its plateau. But yeah, I think it's available. That site is there. It's large. There's lots of appointments left. I would encourage everyone to book. It's ready. It's ready for folks. I don't know if clinically if there's anything else you'd like to add.
No, I think it's very early for us to know whether or not there's something specific to Moderna. Certainly, if there is any hesitancy towards Moderna, I think our clinical team finds that very confusing, and because we've looked at the data and seen how equivalent the data is between Pfizer and Moderna. In basically every trial that has been run, they perform almost identically, which is why we've been so thankful to have both of these options that we can use in Manitoba. Moderna has been using mRNA technology for over a decade in therapeutics as part of cancer treatments, as well as in other vaccines, which is one of the things that helped them so quickly develop the COVID vaccine, was that they already had the delivery mechanism ready to go when this pandemic started. So I don't know if there is actually any hesitancy around Moderna, but if there is, I really encourage people to not feel concerned about Moderna compared to Pfizer, because these both are vaccines that provide stronger protection than we've seen with almost any other vaccine that we have. So we're very confident in both of their ability to protect Manitobans.
From City News, Alex.
Good afternoon. Thank you both for the time. Obviously, no confirmed shipments of Moderna for the month of June. Are you guys concerned with this uncertainty, and will this change projections?
I would say yes, we are concerned with that uncertainty. I think we've been concerned with lack of confirmed shipment deliveries since the beginning of the vaccine rollout. Confirmed shipment deliveries are really what we need to base our hard plans on. We use the projections, the long-term projections to give ourselves timelines, but it's largely our confirmed shipment deliveries that allow us to plan for focused immunization teams and book appointments. In the case of Moderna, the projections in terms of how much we will receive into the province are generally still stable. They're the low supply scenario that we've talked about, but they're stable enough to give us a sense that Moderna will come. The question is just how soon, and we are looking to the federal government certainly to get a confirmed shipment delivery as soon as possible. Particularly when we look at our first doses in arms timelines, which the assumption behind those timelines are no later than June 9th timeline for having everyone who would like a first dose to have one. It assumes that the projected supply from the federal government will bear fruit. And it also assumes a 70% uptake rate. So we're watching for any other news on shipments before we have to adjust those timelines, but it certainly could have an impact on the timeline.
For 18 plus have now received at least one dose, and 55% of 12 plus have received their first dose. Where do we see these numbers in the next month? Obviously, we'd like to see 100% of Manitobans get the vaccine, but that's not going to be realistic. So what's a percentage that we could see here?
So again, I think supply plays a very, very big role there. If we had our confirmed Moderna shipments this week, next week, then assuming uptake keeps up, and accessibility doesn't become an issue at super sites, and there's no indication that it's happening, like that it's to the point where we won't get to 70%, but the booking is leveling off to some degree, so uptake is becoming a factor. But there's no indication that we wouldn't be able to get to 70% if we had the supply available and those confirmed shipments. So we're watching to see what happens on the supply. If there is no more Moderna that comes in, and that's certainly not what we would like, given where booking is right now, we'd probably look still at high 60s for 12 plus, probably very close to 70 for 18 plus, given what's currently in the system. But we need more supply for more people to book. But I know there is an uptake in accessibility piece as we get closer to that 70%. So I think I'll just pivot to Dr. Reimer again if there's anything that I've missed on that front.
No, I mean, really, the supply is the number one issue because all of the uptake in the world doesn't help us get there any faster if we don't have doses to provide. But it's also really important that we start thinking now and start implementing shortly more options for people in spaces that they feel comfortable, because we do want to exceed 70%. So as soon as the supply is available, we want to get as many first doses into people as we possibly can. And so our work is really just beginning on providing more options for people to get that first dose.
From CHVN, Taylor.
Hi, good afternoon, Dr. Reimer. I believe both my questions are for you. We've had some others reach out to us wondering about the safety of the vaccine when they're nursing. Right now, it looks like there's not a whole bunch of studies going on, but what do you know about the safety of nursing when getting the vaccine?
Yeah, so this is a really interesting topic because it's true for almost every treatment, every medication, every surgery, every vaccine, in that people who are pregnant or breastfeeding are excluded from studies. And so in my clinic, I have to have this conversation with people all the time to say that we don't have any evidence from the from the original trials to tell us directly how those trials could have been different, or the outcomes could have been different for people who are pregnant or breastfeeding. And so that's no different this time, where those groups were excluded from the original trials. But what we do have is, 1 billion doses that have been given around the world of these vaccines without any safety signals showing up anywhere in the world related to pregnancy or to breastfeeding. And so that's incredibly encouraging to see, because we would have thought, by the time you hit 1 million doses, you would start to see some negative outcomes if they were there. And no country is reporting any concerns related to fertility, related to birth defects, related to preterm labor and delivery, miscarriage, or anything around infant health if the infant is breastfeeding. So the 1 billion doses so far have not shown any safety concerns at all for this population. What I also would add is that there is a theoretical benefit that we don't have any studies with this vaccine, but we do have studies from other vaccines that show that antibodies, so that response that your body generates to fight off the virus, they can pass through the placenta to the baby when someone is pregnant. And to a lesser degree, they also can be in breast milk for the infant that's breastfeeding. And so to a larger degree related to pregnancy, the infant might be born with some ability to fight off the virus because they have those antibodies in their system already. That may also be occurring with breastfeeding, although to a lesser degree than how it passes through the placenta. So at this point, I would say we have unknown efficacy data from the trials. We have good safety data from real world, and we have theoretical benefits that we haven't yet studied.
And we know people who've gotten their first or second doses of the vaccine have fewer symptoms if they do get COVID. But now, say, people of the 2 doses don't have to isolate if there's that potential exposure. So how is this going to impact the potential spread of the virus?
Well, we're really happy with how well these vaccines work, even after 1 dose, but more so after 2 doses. And so that's something that the public health team will assess as part of their case and contact investigation to ensure that the exemption from isolation makes sense. But at some point, the whole purpose of the vaccines was so that your likelihood of becoming infected and transmitting to other people became extremely low. And the more Manitobans that are protected, the lower that risk gets overall as well. So the purpose for changing the approach to isolation and having this exception available is exactly the intent of the vaccine rollout. We see much less infection and much less transmission in people who were immunized, to the point that we want to be able to still monitor them, still check in, make sure they don't have symptoms, make sure that there's nothing out of the ordinary that would make us concerned, make sure that they don't have any health conditions that would make them more likely to not respond to the vaccine. But with all of those caveats in place, that this was always the intent, was that we would be able to start changing our approaches once Manitobans were vaccinated.
From the Winnipeg Free Press, Danielle.
Hi there. Johanu, my first question is for you. How have you prepared to transport vaccines from the United States if that becomes an option? How many trucks, freezers, and people do you have on standby to carry that out right now?
So our main operations at the moment is really based around receiving shipments of vaccine into our warehouse or to super sites from the federal government. We have, I think, as you know, or as Manitobans maybe know, we have a materials distribution agency that does this as its main line of business, and that can be marshaled in all sorts of ways should we have to pick up vaccine somewhere by road. But our main focus is the confirmed shipment deliveries that we're getting from the federal government, which comes from them right to us.
Okay, thank you. And Dr. Reimer, do you think that the hotspot immunization plan perhaps came too late in the third wave to have a meaningful effect on transmission? In hindsight, do you think that the rollout should have targeted those communities and the associated workplaces where transmission has been consistently high earlier on?
Well, when we have a very small supply available, our strategy is different than when we have a large amount of supply. So when there's only enough doses to cover 5 or 10% of the population, we're not going to be able to have a large impact on transmission patterns, and we're certainly not going to be able to reach anything close to herd immunity. So in a low supply setting like we had for January, February, March, our goal had to be protecting those people who were at the highest risk of severe outcomes like hospitalization or death. And so that's what we did, is we looked at the data that was available to find the most efficient approach to reach as many people who had those high risk of severe outcomes and provide them the vaccine first. The pivot came when we had enough supply that the number of Manitobans immunized could actually potentially impact transmission patterns. And so that's why we chose to change when we did, to look more at things like where we had seen sustained transmission by geography, both in Wave 2 and the new data from Wave 3, because it's simply not effective if only 5 or 10% of the population in any community is immunized to try to target transmission. So as soon as we had enough doses, that was when we moved. If we had had doses earlier to be able to reach a large population, I think it could have had a huge impact on what we saw with Wave 3. And I would have been so happy to be able to target transmission and reach for herd immunity earlier if we could have. But when we had such a limited supply, we really had to figure out who would benefit the most from it outside of an approach for herd immunity.
From Global News, Marnie.
Good afternoon. You mentioned reaching out to more vulnerable communities who may have challenges with accessibility to the vaccine, but when it comes to people who are just vaccine hesitant, not necessarily anti-vaccine, but people who maybe think they can wait or they're low risk because they have very few contacts or whatever it may be, how concerned are you about that, and what kind of message would you want to send to people who have that mindset?
Well, I would say we're concerned about anyone who's not getting the vaccine for any reason. We need to have multiple approaches going on at the same time. For some people, it's an issue of accessibility, access to information, access to booking, access to the super sites. For some people, it is concerns around the vaccine, the most common one that I hear being the speed that it was developed. And so my message to people who are not experiencing barriers but have questions is that we want to provide you with all of the answers that you need to feel confident in this vaccine. The speed that these vaccines were developed was really a product of all the previous scientific work that has gone into mRNA technologies over the last more than a decade. Combined with the fact that the whole world started working together at the same time on the same goal. And so it really showed what we can do as a global scientific community when we come together to try to address the same issue at the same time. So the concerns that people have, I want them to bring those forward and talk to your physician, your family physician. Go to our website at protectmb.ca. Reach out to us, reach out to other trusted health experts who can provide some of that information and background to you. And as the task force, we need to be working as well at reaching individuals, at reaching different communities, and trying to address whatever their concerns may be, in addition to addressing barriers. And that means working with local leadership. because we know for all of us that we are more impacted by what our friends and our family and our local leaders do than we are by somebody in the government giving us information. And that's just normal human response. And so we want to work with those local leaders to give them everything that they need to reach out to their communities and help protect them and prevent anyone else from ending up in the hospital or the ICU.
All right, thank you for that. And on a similar note, if AstraZeneca or now maybe Moderna recipients are concerned that they might not get the same vaccine type for their second dose as their first dose, obviously we're still waiting for more studies on that. But how do you want to kind of address those concerns? And do you think that possibly has an effect with a slower uptake at Lila?
So, we don't know exactly why there's still appointments open at Lila, but right now what we're hearing from the federal government is that there will be enough supply for everyone to get a second dose of the same product when we get to that point. Where we're struggling, as Johanu was describing, is getting the confirmed shipment dates so that we can plan accordingly and make sure that we have the staff in place and all of the clinics ready and to book those appointments. So it's not so much that we are being told that there won't be doses as much as it is that we're having trouble knowing exactly when those doses will be available. But even if they don't become available, we will offer a second dose to everyone because there has already been one study out of Spain that showed that a second dose with Pfizer for someone who received a first dose of AstraZeneca was superior to not getting a second dose. So that doesn't tell us whether or not it's better than getting a second dose of AstraZeneca, but it certainly tells us that we shouldn't be leaving people with no second dose. And so we will absolutely ensure that everyone who got a first dose is offered a second dose, regardless of which products we have available. Though right now, our process is the same as it's been throughout this entire campaign, in that we are following NACI's guidance to stick with the same product for dose 1 and dose 2, recognizing that there is the UK study that should be giving us better information about this by the end of the month.
From CJOB, Joe.
Hi there. So based on today's date, I would imagine bookings for first dose appointments at most sites are at or after that early June date to have everyone with one shot. And Johanu, I believe, correct me if I'm wrong, but you said that earlier, that based on what's in the system today, we don't have 70% of the population signed up yet. But are you confident we can still hit that 70% target in the next couple of weeks?
So it really depends on what comes in from the federal government in terms of the Moderna shipments. It's really a supply ball game. Right now, if we look at and obviously bookings move every day, people are booking every day, so it changes the data slightly. But right now, if we look at the amount of first doses in the system, I would say that we're high 60%, getting very, very close for 12 plus by June 9th. But there isn't enough confirmed supply coming in for us to have enough appointments in the system to literally meet that target. If you think about the amount of people in the province, so let's say that we're 3% off. Let's say that it's 67% by closer to June 9th. That's still approximately 12 plus people. It's still about 38,000 appointments that need to be filled. If we don't have supply for it, we don't have supply for it. So there's appointments left in the system. They're being booked up by dose 1, dose 2. There's a large number of dose 1s in there so that we get 12 plus high 60% by June 9th. But whether we get to 70% is really depending on what happens on the supply. Now, of course, the supply will come in ultimately, and Pfizer just continued to come in. That June 9th projection was based on including Moderna to come in. So, I don't want to lock us into a hard timeline here now because of how volatile the supply information is on on one side of the vaccine types, but I think it's probably feasible to say that we'll clip over that, whether it's mid-June or into June, depending on what the supply scenarios say. We'll get there. We'll absolutely get there, but supply will dictate whether we get there by June 9th.
Thank you. And what's the biggest challenge the task force is facing right now? Is it the securing doses, vaccine hesitancy, or something else that I'm not thinking of here?
I think the theme for today is confirmed shipment deliveries from our side of the house. Operationally, things are running quite smooth. Our super sites are chugging along. People are at super sites, between 25 to 45 minutes on average, including the 15-minute wait afterwards. We do have pop-ups throughout the province. This week, they've always been very, very popular for where we use them. Our focused immunization teams are sort of cruising along the congruent living campaign, supporting a number of smaller pipes, things like corrections. So I think operationally, everything is knock on wood, looking pretty good. The thing that we're looking for is a confirmed shipment delivery so we can keep planning ahead, and that's the big pressure point for us at the moment, so we can plan. That's the operations and planning and logistics side. I think clinically it'll probably be a little different.
Oh yeah, I think definitely on our side, uptake is our biggest challenge. And so, we want to, once we have that supply and once all of our systems are running, we need people to come. And we need to, if they're not going to come, we need to figure out why and address those concerns. So that's certainly the biggest challenge from our side is on the communication and the accessibility to Manitobans.
From the Winnipeg Sun, Scott.
Hi, good morning to both of you. Dr. Reimer, we heard this morning during a technical briefing from Dr. Anderson that stigma and fear is getting in the way of getting tested. I'm wondering, can we extrapolate that with the Premier blaming sick Manitobans for not getting vaccinated? Is that getting in the way, creating fear and stigma in terms of the vaccine campaign and reaching some of the hesitant populations in the province?
I think there are a lot of things that contribute to whether or not people choose to get vaccinated. The stigma around the issues with testing probably don't translate directly to vaccine uptake because we don't have the same sort of enforcement or stigma around receiving a vaccine as we would related to an infection of COVID. So what we're seeing more, and we have a lot more learning to do and connecting with communities to make sure we understand, but what we're seeing so far is not so much a fear of stigma or enforcement, but more questions around the vaccine, around how it was developed, around whether or not the government is trustworthy to provide care to different communities, as well as just simply all of the challenges that people face in getting to an appointment. So our focus right now is to start already addressing where we have learned things and providing services and information based on what we've heard so far, but to continue to reach out and learn and adjust based on the ongoing conversations we have with different communities.
Thanks for that. I guess I'll ask it a different way then. Is blaming Manitobans for not getting vaccinated and getting infected getting in the way of people getting vaccinated? Like, it is just apologies for my dog. Is blaming Manitobans for getting vaccinated or not getting vaccinated, even that in itself, is that becoming a problem? Is that a problem from the vaccine side in trying to get? Is it a barrier, I guess, is what I'm asking.
You know, we have many decades of research around vaccine hesitancy, and what we've definitely seen is that the most important thing that we need to do is demonstrate that we have empathy, because nobody is choosing to not be vaccinated because they want to do something that is harmful. Everybody makes decisions based on what they believe is the best for themselves and for their families. And so it's really important that in the task force, as well as for, I'll speak separately from the task force in my role as a clinician working with pregnant patients. It's critical that when you're talking to somebody who isn't sure about the vaccine, that you don't make them feel defensive about that decision, because they are trying to do what's best for themselves and for their families and their communities, no different than someone who chooses to be vaccinated. And so it's really important that as healthcare providers, as well as communicators through the task force, that we are clear on that point, that we have that common goal. We all want Manitoba to be healthy. We all want Manitobans to get past this third wave and get back to more of the normal life that we had before COVID. We all want to get rid of these public health restrictions. And so if we can start at a point of mutual goal, we'll get a lot further than we will if we start to push back at people and make them feel defensive and make them feel attacked. And so that would be my message to all of us on the task force, as well as to all of the healthcare providers and even those folks who are trying to talk to your family and friends, is to make sure that you're doing it in a way that engages people in a conversation, rather than pushing them to feel that they are somehow being blamed for the circumstances that they're in.
From CBC Manitoba, Bart.
Hi, Dr. Reimer. You mentioned that people who are fully vaccinated won't have to self-isolate if they come into contact with a known case, provided they don't have symptoms. What other benefits or privileges can fully vaccinated people expect?
Well, thankfully, that's mostly a question for Dr. Rusin, because I know that him and the public health team are working on that right now. As we had so few people who had received 2 doses, it was difficult to start making a lot of changes to what people could do based on vaccine status. But now that we're rolling out dose 2 to a larger group of Manitobans, this is the time where the public health team is going to start communicating out different impacts that may have, either at the community level or potentially even at the individual level. We wanted to share this example today so that Manitobans can see that there already is a benefit, again, apart from the health benefits, but there already is a benefit that you may be able to be exempt from self-isolation, because nobody wants to have to isolate. People want to be able to go to work. They want to be able to continue to function in their life and provide all of the things that they need for their families. So this is something that exists already that we wanted to share, but I know that Dr. Rusin is working on this and will have more to share in the coming days or weeks.
Okay, thanks for that. There remains, Mr. Botha, and Dr. Reimer, there still remains, no matter how many times you explain the AZ issue to people, some degree of confusion amongst them and differing practices among doctors and pharmacists. So I'm being told that some doctors and pharmacists are just flat out refusing to somebody who's had it for 4 weeks and saying, nope, wait for 12. And other pharmacies are having walk-in clinics. So what message could you give people right now who got AZ as the first dose, don't have any other underlying conditions, and are aware you're telling them to wait the 12 weeks? What can you say to those people who might be really confused right now?
Yeah, I completely agree. I'm hearing lots of questions about AstraZeneca specifically. So our goal throughout has been to provide 2 doses of the same vaccine consistent with what the trials studied. We don't have any scientific data at this point to tell us if switching products is going to be as effective as sticking with the same product. And I know that many people with AstraZeneca feel like they're being left out of dose 2 or overlooked as far as what they have access to. But we think about it and talk about it many times every day because we do want to provide the best options for everyone, regardless of what product they got for dose 1. And right now, all of the scientific literature that we have used the same product for dose 1 and dose 2. So we don't want to offer somebody a different product if it might provide less coverage or less protection than getting the product that was shown to be highly effective in the studies. And so the 12-week issue for AstraZeneca is a separate question, but often gets blended into the whole discussion because we've started to offer second doses for the mRNA vaccines. So the 12-week issue, it has to do with what we saw in the original AstraZeneca studies, where the efficacy was substantially different between those who got the doses in the 4-week, dose 1 and dose 2 within the 4-week window, compared to those where the second dose was delayed more than 12 weeks. There was a big increase in the efficacy for those people that had their second dose later. And it may even go further if you wait 16 weeks, for example. And so our advice is to most people, if they don't have high-risk health conditions or particular high-risk settings that they may be in for exposure, that we want you to be as protected as possible. We want to give you the best options that we have based on the science as it is today. And so that means that the advice is to wait 12 weeks. But that said, we have sent out communications to all of the pharmacies and the physicians that are participating in our program, letting them know that they can have that discussion with a patient. And if, after understanding that it could be less effective if given earlier, as well as the fact that we're still waiting on this UK study, and so things could change within the next week or two. If the person still wants to go ahead, either because they have a health condition that they're specifically concerned about, or they are concerned about their exposures to COVID, or other reasons, that clinician can provide that second dose based on their case-by-case assessment. So we are trying to communicate that everyone is being treated the same regardless of what dose they received, but the decision-making is happening in different locations, where we in the task force are making decisions about when dose 2 is being given for the mRNAs. The individual physicians and pharmacists are making the decisions about when the second dose is being given for AstraZeneca. But my promise to Manitobans is that as soon as this UK data comes out, if we see that using an mRNA vaccine for dose 2 after AstraZeneca is equivalent or better, we will offer you a dose 2. But I do not want to offer you something if I don't know if it works.
Our final reporter this afternoon from the Canadian Press, Steve.
Oh, hi there. I'm just wondering, now that we're a few weeks into many different age groups being eligible for a first dose, what do the stats on take-up so far tell you about whether we are going to hit or exceed that 70% take-up in the total population?
For dose 2 or for dose 1?
For dose 1, and then presuming that most people who would take you up on dose 1 would continue into dose 2. But in terms of achieving that, getting towards that 70% goal and achieving some sort of herd immunity, what does the take-up so far tell you about whether we'll get there?
Thanks, Steve. So in terms of herd immunity and the epidemiology of that, I will pivot to Dr. Reimer. But in terms of what we're seeing for booking, as I mentioned before, we have enough dose 1s in the system, 12 plus, to be at the high 60% by June 9th. We need more supply to hit the full 70 by June 9th, but then at some point afterwards we'll hit that 70%. That's total. That's 12 plus total in terms of the uptake by each age group and the epidemiological implications of that 70%. That's over to the clinical side.
Yeah, so I would say we will not hit like the hard and fast definition of herd immunity at 70% of 12 plus. We've seen, particularly with the variants that we have now, that having 70% of people over 12 immunized will not be enough to completely stop the transmission of this virus. What we don't know at this point is how high that number needs to get before we hit the definition, like the epidemiologic definition of herd immunity. However, what we have definitely seen is that even if we don't hit that official textbook definition, there is still very clear benefit in the transmission patterns as we're getting above 50%, above 60% coverage. We, as much as wave 3 has been devastating, and it's one of my jobs is to review all of the deaths in folks who are under 60, and reading their charts is heartbreaking. We have prevented many deaths already because of the vaccine campaign. The number of deaths in people over 70 in wave 3 compared to wave 2 is so much better. And this wave would have been much, much larger without this vaccine campaign. We have seen so few outbreaks in personal care homes, whereas that was where the bulk of our severe illness and the bulk of our deaths were happening in wave 2. So even if we, at 70%, don't have a hard stop herd immunity, we are already saving lives. We are already decreasing the height of wave 3. But to get there to the complete herd immunity, we're going to need more Manitobans, and that's going to be a combination of Manitobans stepping up to get their vaccine and us reaching out to lower those barriers.
And have you folks been consulted on the idea of incentives to encourage more people to get vaccinated? I see, in other parts of the world, there are a wide degree of incentives. In New York State, they're entering people into a raffle, specifically the younger age group, into a raffle for scholarships.
So there's been a lot of conversations about incentives, and those conversations are ongoing. I don't think the government has made any final decisions about that. I have also heard of some private companies that have offered financial bonuses to staff who have been immunized. So that's already occurring. I know some of the communities that ran pop-up clinics held some raffles as well in their community to help boost uptake. So we are certainly open to looking at ways to incentivize people beyond the benefits from preventing COVID, beyond getting rid of the public health restrictions. If there are ways that we can tip people over who may be considering it but just haven't been able to prioritize it, we're certainly open to that and looking at how best to do that in a way that leads to protection for all of us.
Thanks, everyone. This concludes our media briefing.